Good morning. I'd like to start the session by introducing our first speaker, Dr. Colleen Nofi, who will be presenting on extracellular cold-induced RNA-binding protein exacerbates necrotizing enterocolitis.
Good morning. As mentioned, my name is Colleen Nofi, and I'm a resident at Cohen Children's Medical Center in New York, and I'm excited to present our work on extracellular CRP exacerbates necrotizing enterocolitis. I'm an inventor of our patent on our related molecule, and I have no other conflicts of interest to disclose. As we know, NEC is a devastating gastrointestinal disease primarily impacting premature infants. The reason I did this research is that the pathophysiology of NEC is driven by a multitude of factors and complex pathways that are not completely understood. Further, there are limited treatment options and high morbidity and mortality risk. Why I'm presenting this work today is to address these gaps and highlight a new factor and potential treatment option for necrotizing enterocolitis. My work focuses on a protein called cold-inducible RNA protein, or CIRP. Under biologic conditions, CIRP is found inside the cell where it acts as an RNA chaperone protein. Under states of cellular stress, like in sepsis, CIRP actually escapes outside the cell where it becomes extracellular CIRP, or eCIRP. And eCRP's function completely changes, where it now functions as a damage-associated molecular pattern, or DAMP, by enhancing the release of inflammatory cytokines and chemokines and worsening the inflammatory cascade. I previously developed an eCIRP scavenging peptide named MFGE8-derived oligopeptide 3, or MOP3, that removes eCRP from circulation to attenuate inflammation. Before this work, the role of eCIRP in gastrointestinal inflammatory diseases like NEC was unknown. Thus, the aims of my work were to determine whether eCIRP plays a role in exacerbating necrotizing enterocolitis and to evaluate the therapeutic potential of our eCIRP scavenging peptide, MOP3, to protect against NEC severity and mortality. So we utilize a murine model of NEC where we subject pups to hypercaloric formula gavage, enteric LPS, and hypoxic stress. And we utilized both wild-type and CIRP knockout pups to address AIM-1. And we utilized our MOP3 treatment, or a vehicle, to address AIM-2. First, we found that CIRP knockout protects against NEC severity. Here you can see representative H&E stained images where you can appreciate the protection of the intestinal villi architecture in our CIRP knockout NEC pups. And this was significant when we quantified for NEC severity, as shown by the green bar here. Further, we showed that CIRP knockout protects against intestinal inflammation and barrier function. So first, we appreciated that mRNA levels of both IL-6 and TNF-alpha in the small bowel were significantly reduced in CIRP knockout NEC pups compared to wild type. And to probe the intestinal barrier function, we administered a fluorescently labeled dextran enterically. That way, if the intestine was injured, the fluorescently labeled dextran would leak outside an injured gut and be detectable in the serum. So here you can see increased fluorescence intensity in our wild-type NEC pups, indicating breakdown of the intestinal barrier, whereas the fluorescence intensity was significantly reduced in our CIRP knockout pups, suggesting protection of the intestinal barrier function. Finally, we looked at the impact on survival, and we found that in the same model under the same conditions, the CIRP knockout NEC pups had 100% survival, whereas this was significantly reduced to 65% in the wild-type NEC pups. We next transitioned to our treatment model using our MOP3 treatment peptide, and we found that MOP3 treatment functioned as it was designed, as we saw a decrease in the systemic levels of eCRP with MOP3 treatment in NEC indicated by the orange bars here. We also corroborated a reduction in other inflammatory markers, such as systemic IL-6 and TNF-alpha with MOP3 treatment. We also found that our MOP3 treatment protected against neck severity, and here you can see protection of the intestinal villi architecture, and this was again associated with a reduction in neck severity, as indicated in the orange bar. We again looked at intestinal inflammation and barrier function, and we found that our MOP3 treatment reduced mRNA levels of both IL-6 and TNF-alpha in the small bowel. And again, when we looked at the intestinal barrier function using our fluorescently labeled dextran administered enterically, we found that MOP3 treatment was associated with a reduction in fluorescence intensity, indicating a protection of the intestinal barrier function. And finally, to probe the potential clinical significance, we looked at the impact on the overall survival, and we found that our MOP3 treatment was associated with a significant improvement in survival, up to 80%, compared to our vehicle treatment, which was only 50%. This highlights the potential therapeutic implication of our MOP3 treatment in experimental neck. So our work has highlighted a completely new factor in neck pathogenesis, where ECIRP increases inflammation and intestinal injury that exacerbates neck pathogenesis, whereas treatment with our novel peptide, MOP3, helps to attenuate neck severity and improve survival in experimental neck. So thank you to my scientific and clinical mentors at Northwell Health, and I'm happy to take any questions.
Please.
Hello, good morning. Kathy Hunter from Oklahoma. Fabulous presentation, and so important here on Neck Awareness Day, May 17th. A couple of questions. So when you're looking at your barrier function, did you also look at the degree of apoptosis? Because one of the things when you're looking at your FITC dextran, I'd be curious to know what size you're using, because perhaps you're looking at permeability, paracellular function, but you could also just be looking at the loss of barrier integrity as well.
Thank you for the question. So we started with a FITC dextran, which was FITC like 40, but we also have used creatinine, and we have other molecules of different sizes to try to probe exactly what effect on the barrier function is. So that's ongoing. And to address your question on cellular apoptosis, we have performed tunnel staining, and we showed a reduction, but we don't know exactly what cells in the intestine from the tunnel staining are the ones that are apoptotic or protected against apoptosis in our treatment model. So that's something we also need to look into.
Yeah, because at 40 will be loss of the actual barrier, whereas if you're looking at creatinine, that's really going to be much more helpful for your paracellular function. Perfect.
Thank you.
I'm so sorry. Due to time, we're going to have to move on to the next presentation.
Thank you.
Our next presentation is the reduction of a pediatric gastrostomy tube, healthcare utilization, and socioeconomic disparities, longitudinal benefits of quality improvement, presented by Dr. Juveler out of Rochester, New York. Dr. Juveler, the stand is yours.
Thanks for having me. We have no conflicts. So we engage in this research to examine whether improvement efforts may be an effective tool to support care equity. G2 complications are common and result in emotional and financial burden for caregivers, as well as hospital system utilization. This project is built upon previous improvements implemented in 2018 and 2019, which were rooted in care consensus and caregiver nursing education. Following these interventions, inpatient dislodgement decreased from 14 to 1%, and outpatient dislodgements from 29 to 18%. Next, the team focused on outpatient dislodgements. About 20% of patients accounted for 80% of ED visits. This subset was named high ED utilizers, defined as patients with 2 or more ED visits. High ED utilization was related to non-white race, high area deprivation index, and surgeon. So we hypothesized that improvements focused on G-tube, reducing G-tube complications and ED visits would be associated with diminished socioeconomic disparities in outcomes. Our additional interim improvements include informational website for caregivers, community education, and most recently, a peer support network for our new G-tube caregivers. NISQUIP Pediatric was used to identify children aged 17 years or younger who underwent gastrostomy tube placement at our center between 2011 and August 2022. Dislodgement and ED visit data were gathered retrospectively prior to the intervention and prospectively following the interventions. Address at time of admission was used to assign a national ADI score for each patient. Data were analyzed by process control methods and univariate analysis. A quick reminder about ADI, it's a 17-variable composite based on U.S. Census Bureau data at the census block group or neighborhood level. It includes factors relating to income, education, employment, and housing. Higher ADI scores equate to less advantaged areas, and lower ADI scores to more advantaged areas. To study the potential impact of neighborhood on G-tube outcomes, we compared children with an ADI score of less than 80 to children with an ADI score of 80 or greater in both the pre- and post-intervention periods. We included 372 children. There were significantly more children identified as Black or African American and higher rates of government insurance in the high ADI group. Otherwise, there are no demographic differences between ADI groups. The percent of high ED utilizers, or those with 2 or more ED visits, pre-intervention was 21% for the low ADI group and 39% for the high ADI group. Post-intervention, they accounted for 13% of the low group and 24% of the high group. Here, this difference is no longer significant, though there is room for clinical improvement. Pre-intervention, 15% of children in the low ADI group had a G-tube outpatient dislodgement within 90 days, compared with 33% in the high group. Post-intervention, dislodgements were no longer statistically nor clinically different, representing 11% of the low group and 8% of the high children. Here's a control chart demonstrating the number of early dislodgements per G-tube placed by quarter year for the low ADI patients. That dashed center line you can see in the middle displays the mean. Initially, there were 0.2 early dislodgements per G-tube placed. In other words, there were 2 early dislodgements for every G-tube placed. Beginning in quarter 3 of 2019, we see a shift in the center line to 0.1, which corresponds with the initial wave of interventions and sustains for 4 years. Now here's the same chart, this time for the less advantaged children. We see that dashed line, the initial mean of 0.5 dislodgements per G-tube, shifts to 0.1, converging with the more advantaged group. Ultimately, we demonstrate that a long-standing G-tube improvement effort has led to sustained gains, and we estimate that at least 28 early dislodgements were avoided. Disparities in ED visits and early dislodgement appear to be mitigated in the post-intervention period. Care standardization may help address disparities in outcomes by controlling for potential bias at each stage of care. Finally, I'd like to thank all our authors, including our mentor, Dr. Derek Wakeman, and share that more details about our QI initiatives can be found at the APSA Quality and Safety Toolkit. Thank you.
All right, thank you for a nice presentation. This paper is now open for discussion from the floor. Anyone on virtual chat? Okay. A question about, did you differentiate at all between those G-tubes that were placed in the inpatient setting versus those that were placed for patients coming in as outpatients?
Everyone was included, so it included the NICU patients or the outpatients, yeah,
Okay.
all the way to outpatients.
When you're just going through the data, did you notice any differences just on your sort of scan of outcomes, just in the context that patients who have been inpatients can potentially have more extensive training?
Okay, what was that last part? I'm sorry.
That patients who have their G-tubes done as inpatients may have more extensive training from the inpatient staff.
I see.
Is there anything that you noticed just scanning the data?
We have, part of our issue initially was to sort of have a consensus amongst the education for all floors. So there was a little bit of difference between the NICU education versus the floor education. So we're trying to unify that. That was part of the effort. So.
Great. Okay, please. Or whoever's first.
Okay, thank you so much. This was really refreshing. In fact, you didn't start describing the disparities. You jumped right into an intervention, so thank you. My questions are twofold. One is that did you find a difference between, and I saw you're using the social deprivation score, did you find a difference between insured, household insured, or whether they were publicly insured or privately insured, with differences in seeking out care and coming back and reporting complications? And then secondly, could you speak a little bit about the intervention and the cost? Were there costs to equipping people with the app? Were there additional FTEs on the nursing perspective to do the follow-up? I'm interested in the cost for the intervention.
Thank you. To answer your first question, we didn't analyze based on insurance status independently, but we do know that those higher ADI groups did have a higher percentage of government insurance. In terms of the interventions, it definitely takes someone to lead it, and we're lucky enough to have a champion like Dr. Wakeman who follows these projects through. I think that makes a huge difference. The actual interventions themselves, a lot of it was around care consensus that takes time. There wasn't so much so FTEs as much as bringing a group and a team together, multidisciplinary team, sort of address the problem. Probably the thing that cost was we provided patients with G-tube dislodgement kits. They were able to practice with those before, so maybe that was one of the costs, but not a ton of additional cost in that sense. So.
I apologize, we only have time for that one question due to time.
Okay. Thank you
for your presentation.
Next will be screening ultrasounds for deep venous thrombosis detection and high-risk pediatric trauma, a report from the Midwest Pediatric Surgery Consortium no-clot study, presented by Dr. Amanda Whitty.
There are limited recommendations on screening ultrasound following pediatric trauma. Screening ultrasound may help identify otherwise asymptomatic DVT in high-risk patients, allowing for treatment prior to complications. However, existing guidelines regarding the use of screening ultrasound following trauma are conflicting. Adult guidelines recommend screening ultrasound in high-risk patients, but give no advice on timing or patient selection. In contrast, pediatric guidelines recommend against screening ultrasound due to low-quality data and anticoagulation risk. Additionally, this recommendation focuses on all children and not just those at high risk. We wanted to better define the role of screening ultrasound following high-risk pediatric trauma. The no-clot study was a prospective study conducted at 8 Level 1 pediatric trauma centers in the Midwest Pediatric Surgery Consortium. All pediatric patients were screened on admission using 13 mutually agreed upon high-risk criteria and included in the study if less than 8 years of age with at least 2 high-risk factors or older than 8 with at least 1 high-risk factor. We previously reported results of our primary aim, which showed that use of chemical prophylaxis was safe and most effective when given early. This presentation focuses on the second aim to define the role of screening ultrasound. All patients in the study were recommended to undergo screening ultrasound on day 7, regardless of receipt of chemical prophylaxis. Bilateral lower extremity duplex ultrasound was performed with the addition of upper extremities if there was a prior central line. At the time of this study, only 3 of the 8 institutions were using screening ultrasound routinely, and thus the ultrasound data came primarily from those sites. During the 3-year study duration, 460 high-risk patients were identified and included. 77% of patients remained admitted on day 7, and 18% of eligible patients underwent screening ultrasound. An additional 21% of patients underwent symptomatic ultrasound during their hospitalization. There's a median age of 14 years in patients who underwent screening ultrasound and who did not. Patients who underwent screening ultrasound were more severely injured by ISS and had increased ICU and hospital total length of stay. Looking at our VTE high-risk factors, screening ultrasound patients had higher rates of central line placement and shock, However, injury-related factors such as TBI, spinal cord injury, and non-weight-bearing fractures were similar between the two groups. There were 10 DBTs identified on 63 screening ultrasounds for a detection rate of 16%. 13 DBTs were identified on symptomatic ultrasound, and the most common presenting symptoms were swelling and fever. Interestingly, the symptomatic ultrasound identified DBTs were identified at a median of 6 days, which was prior to the recommended day 7 screening ultrasound. Of the 10 screening ultrasound identified DBTs, 9 were associated with central lines. 1 patient developed pulmonary embolism after DBT diagnosed on screening ultrasound, and 8 patients were treated with therapeutic anticoagulation with 1 minor and 1 major bleeding complication. The major bleeding complication required a return to the operating room for fasciotomies. No DBT sequelae were seen in the 2 patients who were not treated. Limitations of this study center on barriers to implementation. Only 18% of eligible patients underwent screening ultrasound as recommended due to differences in institutional practices, which introduces potential selection bias and distortion of the true VTE rate. Widespread adoption of screening ultrasound has historically been limited by concerns for cost and impact on quality measures, creating surveillance bias. And finally, the overall clinical consequence of asymptomatic and untreated DBT remains unknown, limiting our conclusions. In summary, use of screening ultrasound at 1 week identified asymptomatic DBT at a high rate, the majority of which was central line associated. We observed that screening ultrasound helped identify pulmonary embolism in 1 patient, but that the treatment of asymptomatic DBT also led to bleeding complications. As such, the benefit remains unclear, though performing screening ultrasound earlier than 1 week may capture more of the DBT that later progressed to symptoms. Finally, better understanding the natural history of untreated DBT may help inform future screening ultrasound guidelines. Thank you.
Thank you for that presentation. We're open for questions.
Hi, great presentation. Jamie Robinson from Nashville. Just one question. The screening ultrasounds that were performed, the 63, how many of those individuals were treated with prophylactic anticoagulation?
Very few. Thank you for that question. Very few. We divided prophylaxis status into receiving within 24 hours and after that. About half of the patients had received delayed prophylaxis, and very few had received prophylaxis within 24 hours as recommended.
And of those individuals who developed DVTs, had any of those received prophylactic anticoagulation?
Yes, in a delayed fashion, but not early.
Thank you.
Yep.
We have time for one more brief question.
And I will be brief. Chris Newton, UCSF, thank you very much for doing this. It's a really, really tough problem and elusive to get good data. So if I'm interpreting this right, the bottom line is screening is worthwhile if there's a central line associated. So clarify for me, when you say central line associated, does that mean in that population the line was still in? Or are these kids who had a line for days and then removed and updated?
Yeah.
What is that group?
Yeah, thank you for that question. So we define central line associated clot as having a current or prior central line located at the location of the clot. And it is correct that our takeaway from this is that it identified central line associated clot, but also if not prepared to treat those clots, then the question of the role of screening ultrasound is even more unclear.
All right, wonderful. Thank you very much.
Yeah, thank you.
And our next presentation is Personal Characteristics Are Associated with Imposter Phenomenon Amongst Pediatric Surgeons, be presented by Dr. Matthew Byrne. Dr. Byrne, welcome to the stage.
Thank you. Thank you, Dr. Wilson, for this opportunity. I have no disclosures. This work was generated by 4 highly accomplished pediatric surgeons that were discussing some of their early career difficulties. For this talk, imposter syndrome, imposter phenomenon, and imposterism will be used interchangeably. It was first described by Clance and Imes in 1978 when studying high-achieving women who were unable to internalize their own success. It is best understood through the organizational behavior literature. They break it down into risk factors, mediators, and outcomes of imposterism. For the pediatric surgeon, this results in burnout, exhaustion, and family conflict. For the hospital system, it results in lost productivity and low organizational commitment. And it can have dire consequences for the pediatric surgical patient due to lost creativity and self-handicapping. But for this talk, I'm going to focus on the risk factors and mediators of imposterism. Our hypothesis is that imposterism in the pediatric surgeon is a result of personal, training, and practice-based factors. We conducted an anonymous APSA survey utilizing the Clance Imposter Phenomenon Scale, a well-validated 20-question, 5-point Likert scale with higher scores resulting in worse imposterism traits. We then asked about demographics, fellowship, and practice characteristics. We had a 30% response rate, and 75% reported at least moderate imposterism. I'll first start with the risk factors. We found that fellows and junior attendings had higher SIP scores than attendings with more than 5 years of practice. We found that females and non-partnered individuals had higher SIP scores than their counterparts. We also looked at race and ethnicity, but had limited power in the non-white and non-Asian categories. Next, I'll talk about mediators. First, we found that those that required more than one attempt to pass the certifying exam to have higher SIP scores than passed on their first attempt. Interestingly, this was not shared with the qualifying exam. All surgeons have complications, so we asked specifically, how does a complication impact your confidence? And those with high negative impact after a surgical complication had higher SIP scores than those with a mild impact. Now, it's difficult to really know the directionality between imposterism and some of these mediators. Finally, we asked respondents if they had anyone to call to talk about a difficult case. And those with a lack of perceived support had higher SIP scores than those who had someone to call. So again, these are the risk factors: fellows, junior attendings, females, and non-partnered individuals, although it's not unique to these groups. Failing the certifying exam, having a surgical complication, and having perceived limited support can be mediators of imposterism. We looked at things that did not have a relationship with imposterism. These included fellowship and practice-based characteristics. So number of cases during fellowship, the number of fellows, and geographic region did not have an association. Practice characteristics such as setting, number of partners, and geographic region also did not have an association with any imposterism SIP scores. There's limitations to consider. First, at a 30% response rate, there's limited generalizability to the entire audience. Selection bias can be at play here for those that were interested in imposterism and wanted to learn more. And finally, as I talked about, the directionality of imposter syndrome and some of the mediators is difficult to ascertain. So in conclusion, imposterism impacts the pediatric surgeon. Personal characteristics, not fellowship or practice-based characteristics, impact imposterism. And moderating factors include momentary points of failure and having limited perceived support in practice. APSA has multiple resources to use, especially after a surgical complication, and the certifying exam can be a point during training to prevent imposterism. Thank you, and I'll take any questions.
So thank you for bringing this important data to us. As we care for ourselves and we care for our colleagues, this paper is now open for discussion.
Very nice presentation, Andreas Meyer, Syracuse, New York. Have you looked at other highly professional professions and what the rate of imposterism is? Because I think we're not alone with this problem.
Yeah, so the first paper was in the academic setting. It was at high-achieving women in the academic setting. There's been some recent papers from a surgical perspective. I'd say the best one done is in the trauma literature that was published about a year ago. And then they looked at general surgery residents, pediatric surgery residents. But to be honest, the SIP score that's been around for about 50 years now has been well validated across many professions, pilots, lawyers, across the board. To repeat the question.
Just to repeat the question for those who weren't able to hear. So the question is whether there is, have you looked for discordance between the practicing surgeon and their immediate supervisor?
Thank you for the question. Very interesting. That wasn't a part of this anonymous APSA survey, but would certainly be something worth looking at in the future.
Great. Okay, thank you very much.
Thank you.
So our next presentation will be sensory recovery following intercostal nerve cryoablation for the Nuss procedure, presented by Dr. John DeFury.
Thank you. Good morning. I am a consultant for AtriCure. The study was performed to increase understanding of the sensory recovery following cryo. It is being presented today to help surgeons understand the time frame for sensory recovery and potential side effects that can occur. We performed a single institution prospective study of 121 patients undergoing cryo during the Nuss procedure. The primary outcome was time to return of normal sensation. Secondary outcomes included hypersensitivity, other forms of altered sensation, postoperative neuropathic pain, and chronic neuropathic pain. Cryo was performed from T3 to T8 bilaterally, and following cryo, we also performed nerve blocks with subpleural injections of Marcaine. Patients were first seen at 1 month after surgery, then seen every 3 months at 3, 6, 9, and 12 months post-op. After the first year, we saw them every 6 months until the bars were removed at 3 years. Median follow-up was 2.7 years, and 93% of patients attended all of their post-op visits in the first year. Cutaneous sensation was evaluated at each visit by physical exam using light finger touch as the stimulus. The median time to normal chest wall sensation was 6.0 months, with a range of 1 month to 12 months. Normal sensation returned as follows. By 3 months post-op, 15% of patients had normal sensation. By 6 months, 62% had normal sensation. By 9 months post-op, 85% of patients had normal sensation, and at 1 year, 98% had normal chest wall sensation. 2 out of the 121 patients had a small 2 by 3 centimeter area of persistent numbness in the lowermost central sternum at the T5 dermatome. In virtually all patients, sensation returned from the lateral chest wall toward the midline and from the upper and lower chest wall toward the center of the chest. The lowermost central sternum was invariably the last area to return to normal. The most common altered sensation was hypersensitivity, which occurred in 21%. This began on average at 3 months post-op and lasted a median of 1 month. 3 of the patients had hypersensitivity longer than 3 months. In all of these cases, the hypersensitivity resolved. Of patients who had hypersensitivity, 20% did describe it as painful, and all of these were successfully treated with gabapentin and/or capsaicin cream. The average duration of gabapentin use to resolution of pain was 2.7 weeks. Capsaicin cream we used in 1 patient who had not been treated successfully with gabapentin. 6% described tingling or pins and needle sensations, and 1.7% described burning sensations. 1 patient in each of these groups felt it was painful, and both were successfully treated with gabapentin. In total, 5.8% of patients complained of some neuropathic pain following cryo, and all of these resolved with medical treatment. There were no cases of chronic neuropathic pain. Both patients with the 2 by 3 centimeter area of persistent numbness did have sternal elevation, which included the application of a tenaculum horizontally on the distal sternum, grasping each lateral sternal border in the same area as the subsequent numbness. It's possible that during application of the tenaculum, the anterior cutaneous branch of the intercostal nerve may have been injured, and this could be the cause of numbness as opposed to the cryo. In conclusion, sensory recovery following cryo is a slow, gradual process that ultimately leads to normal sensation in virtually all patients by 1 year. Hypersensitivity is more common than expected, but is rarely described as painful and always resolves. Gabapentin and capsaicin cream are effective in treating postoperative neuropathic pain. Persistent numbness was observed, but is rare, limited in scope, and could be due to technical factors unrelated to cryo. Importantly, there were no cases of chronic neuropathic pain. Thank you.
Thank you for that presentation. It's now open for questions.
Sung Kim from UCSF. I think the key to preventing neuropathic pain is to do a complete cryoablation. So it's very important to apply the probe to the nerve with pressure, so you get a complete cryoablation. So if you get a partial cryoablation, that's probably when you could get incidences of neuropathic pain. In addition, the intercostal nerve has 3 branches, and it's possible that when you do the intercostal branch on the lower part of the rib, you may partially burn the collateral branch on the bottom side, which then again leads to a partial cryoablation, which then again could lead to some neuropathic pain.
Thank you, Dr. Kim. I loved your paper, by the way. Dr. Kim and his group wrote a fantastic paper with cadaver dissection of the intercostal nerve, which I think is key. And I don't think in our case it was an issue of not enough pressure on the nerve, because I do emphasize that pretty well. I'm interested to speak with you more about your technique of actually focusing your cryoablation on that communicating collateral branch, which I was unaware of until I read your paper. So I think that may be potentially the issue with a partial cryoablation, as you mentioned. And I'd be interested to know what your incidence of hypersensitivity postoperatively is with your new technique, where you also ablate that communicating collateral branch on top of the rib.
Maybe a little bit biased, because maybe I don't want to see any complications, but I haven't seen any hypersensitivity problems.
Okay, well, I'm looking forward to talking to you, because I think that's a very interesting technique.
I'm sorry, and in the interest of time, we're going to have to move to our next presentation.
Okay, thank you.
Please feel free to reach out to the speaker afterwards.
And our next presentation is the effect of race on evaluation and treatment of adnexal masses in pediatric patients, presented by Dr. Taylor King from Emory. Dr. King, the podium's yours.
Thank you. Good morning, everyone. My name is Taylor King, and I am a current OBGYN resident at Emory University. The project we are presenting today is called The Effect of Race and Surgeon on Evaluation and Treatment of Adnexal Masses in Pediatric Populations. The reason we chose to do this study is because we know that there are racial disparities throughout medicine, but there's limited data demonstrating the effect that these disparities have in the pediatric population specifically experiencing an ovarian mass. It's important that these disparities are recognized and addressed so that we can improve health outcomes in a population at risk of marginalization by medicine. I have no pertinent conflicts to disclose. We know that a small proportion of girls are affected by pediatric ovarian masses annually, but that malignancy rate is very low in this population. Because malignancy is so rare and the effects of unilateral oophorectomy are lifelong, the recommended surgery is ovarian-sparing surgery over oophorectomy. Despite this recommendation, rates of ovarian-sparing surgery vary widely by region, hospital system, and surgeon subspecialty. We are specifically looking at whether or not patient race and surgeon background characteristics have any bearing in this population in terms of surgical management decisions and overall patient outcomes, as this has not been previously documented in the literature. Our project was a retrospective study examining females less than 18 years old who presented to Children's Healthcare of Atlanta with an ovarian mass over a 12-year period. We specifically examined patient and surgeon demographics, as well as preoperative evaluation, which included tumor markers and imaging modalities, specifically examining whether or not there were certain characteristics identified that were concerning for malignancy, and then we performed an analysis. Our final population had 409 individuals, and we had a malignancy rate of 7%, which is on the lower end of what's been previously recorded in the literature. Our average population age was 13 years old. 48% of our population was white, 41% was black, and the remainder were Asian or other race. The majority of our surgeons were white male individuals of the pediatric surgery subspecialty, and you can see that over our 12-year period, the racial groups of our surgeons were white and Asian. When we evaluated preoperative results, we found that there was no difference in rates of collection or elevation of tumor markers by patient race in our group. We also found that there was no difference in frequency with which any imaging modality was performed by patient race in our group. We did find that Black girls were more likely to have a concerning imaging feature on imaging. However, we believe that this is due to the fact that Black girls were also more likely to have teratomas on final pathology, and that the imaging was picking up more teratomas, which we know are benign. When we evaluated surgical management by patient race, we found that Black girls were significantly more likely to undergo oophorectomy compared to their white counterparts, despite the fact that there were no differences in malignancy rate by patient race in our population. We also examined social determinants of health and whether or not there was an impact of social determinants of health on surgical procedure, and we found that there was no difference. When we evaluated surgical management by surgeon characteristics, we found that female surgeons were more likely to perform ovarian-sparing surgery compared to male counterparts. And we also found that white surgeons were more likely to perform ovarian-sparing surgery on white patients compared to their racially discordant counterparts. We also evaluated rate of oophorectomy over time at our institution and found that overall, the rate of oophorectomy did decrease. We believe this was due to several factors, including changes in the recommendations by pediatric gynecology favoring ovarian-sparing surgery over oophorectomy in this population. We also found that the creation of a pediatric gynecology department at our institution may have influenced this, and as you can see, with the hiring of more female surgeons, our rate of oophorectomy also dropped. What we can conclude from our study is that there was no significant difference in preoperative evaluation by patient race, but that Black girls were significantly more likely to undergo oophorectomy despite the fact that there was no difference in malignancy rate by patient race. Female surgeons are more likely to perform ovarian-sparing surgery, and white surgeons are more likely to perform ovarian-sparing surgery on their racially concordant patients. Ultimately, we intend to use this research to develop a standardized preoperative evaluation protocol at our institution to decrease the role that any sort of implicit bias may play in patient management. We will then prospectively evaluate this research and determine the effect of patient and surgeon race, as well as gender, on patient surgical outcomes. This study has also influenced the development of a departmental group called the Pediatric Surgery Center for Health Equity, which will be examining the effect of health disparities on outcomes in our patient population and using quality improvement projects to improve overall health equity in our population. Ultimately, this research serves as a call to action for the further diversification among surgical subspecialists. Thank you all for your attention, and a huge thank you to my fabulous group at CHOA and at Emory.
Thank you for your very clear presentation. This presentation is now open for questions.
Paul Lostley, Liverpool, England, Bangkok, Thailand. We've published quite a bit about this within the UK experience. And what I would like to ask you is two questions. I think you probably alluded to it in your closing slide. One is, out of hours presentations, because that is the real danger. When you get out of hours presentations, you may find a higher rate of oophorectomy being undertaken by a general pediatric surgeon versus an oncology surgeon. And I didn't see a reference list, but I'm sure our papers are there. One of the big issues is, of course, who should care for the patient with the pediatric mass. And I believe that should be an oncology pediatric surgeon or a pediatric adolescent gynecologist. And when you implement that, organ-sparing surgery is the savior of these patients. I was really concerned to see your oophorectomy rates versus race. That really concerns me. Thank you for your talk.
Yeah, thank you so much for those points. Yes, it's also something that was very concerning to us as well. And certainly having a multidisciplinary group to address these masses is, I think, the way we're moving.
Any online commentary? Okay, thank you for bringing your presentation with us.
Thank you so much.
All right, our next presentation will be the current state of splenectomy in hemodynamically unstable pediatric blunt splenic injury, a TQIP study, and this will be presented by Dr. Scott Aldridge.
Awesome. Thank you for the opportunity to present today. We have no disclosures. We conducted this research as there's evidence to suggest that many pediatric patients go to the operating room for splenectomy prior to receiving a blood transfusion. I am presenting today to highlight an area where we may improve our care in the hemodynamically unstable pediatric patient who presents with blunt splenic injury. Our group has previously presented on the national trends in the management of blunt splenic injury in pediatric patients using the KID database. We reviewed this database between 2012 and 2019 and found that splenic salvage was approximately 95% in all comers with splenic injury. However, during this study, we found something a bit alarming. Just under 3/4 of patients who went for splenectomy did not receive blood prior to going to their splenectomy. Due to the limitations of the KIDS database, we were unable to figure out why. Additionally, in 2015, the Atomic Plus Research Consortium presented their updated guidelines for blunt splenic injury. These guidelines recommend a trial of non-operative management in all patients that come to the trauma bay with blunt splenic injury. Specifically, for patients that present with recent or ongoing signs of bleeding, they recommend first a fluid resuscitation, followed by an assessment for response. Following this, if patients don't respond, they recommend giving blood, again with an assessment for response. And finally, in patients with continued hypotension despite blood transfusion, an evaluation in the operating room is recommended. Given this data and this background, we sought to describe the contemporary management of patients who present with hemodynamic instability and have blunt splenic injury. We also sought to evaluate the timing of blood transfusion in relation to splenectomy. And finally, we sought to identify risk factors associated with splenectomy in this group of hemodynamically unstable patients. To do this, we conducted a retrospective review of the Trauma Quality Improvement Project database. We included all pediatric patients who had a diagnosis of blunt splenic injury and who had initial vital signs of hemodynamic instability, as defined as a shock index of greater than 1.1. Additionally, we excluded all additional intra-abdominal injury and transfers to the trauma center. We identified splenectomy rate using procedural codes. We next assessed bleeding or a blood transfusion in relation to splenectomy. And then we conducted a multivariate logistic regression to identify patient and hospital factors associated with splenectomy in this group of patients. In total, we identified 516 patients that met inclusion criteria, of which the mean age was 12, with the majority being adolescent. The majority were male. More than half were cared for at a pediatric trauma center. And additionally, another half were cared for at an academic center. In total, 27% of patients who presented with hemodynamic instability underwent splenectomy. We next reviewed the timing of transfusion in relation to splenectomy, represented here in this bar graph. The x-axis of this bar graph represents time intervals of transfusion prior to splenectomy, and the y-intercept represents the proportion of patients in each time interval. Surprisingly, we found that over a quarter of patients go to the operating room prior to receiving blood. Additionally, we found another 11% of patients go to the operating room within 20 minutes of receiving their blood transfusion. This data suggests that the decision to go to the operating room was made in approximately 1/3 of patients prior to this prior to an evaluation of blood transfusion, or in other words, the decision to go to the OR may have been made prior to the decision to transfuse. We next performed a multivariate logistic regression to identify factors of splenectomy. We found that the highest risk was being an adolescent-age patient. We also found that grade 4 and 5 splenic injuries, receiving a blood transfusion, a lower GCS, and a higher ISS were all associated with splenectomy. Interestingly, hospital factors, including pediatric verified trauma center and academic centers, were not associated with splenectomy in this model. The limitations of the study that need to be addressed are we used a nationally kept database. With this, there's a certain level of data granularity. We also used ICD-10 codes to identify splenic injury, splenectomy, and timing of blood. There may have been errors in this coding. And finally, the TQIP only collects data from trauma centers, and these findings may not be generalizable to everyone in the public. To conclude, more than 70% of patients with BSI, or blunt splenic injury, who present with hemodynamic instability avoided splenectomy. I think this really needs to be commended. Second, when we're addressing or evaluating children with blunt abdominal trauma in the trauma bay, and there's concern for splenic injury, these patients need to receive blood prior to going to the operating room. As we saw that 1/3 of the patients in our study may not have received an adequate evaluation of response to blood transfusion. And finally, special attention is needed when caring for the adolescent age group, as they have a higher risk for splenectomy. Thank you for your time, and I'm happy to answer questions. Here are links to the Atomic Plus guidelines, as well as APSA guidelines for blunt splenic injury. Thank you.
Thank you for that presentation. We're open for questions.
Congratulations, Scott. That is a terrific. Tony Escobar from Mary Bridge. I'm not sure I understand the timing of the imaging that led to the correlation between a grade 4 or grade 5 splenic injury and the decision to go to the OR. I don't know how many are going to the CT scan in an unstable patient, but I'm having a hard time correlating what that looks like clinically.
Yeah, thank you. I appreciate that question, Dr. Escobar. That is a great question. You know, with the TQIP database, they provide a grade of splenic injury either using ICD-10 codes or using the AIS. And so we confirmed with both of those codes to determine what the actual grade of the splenic injury was. You know, we can't suss out whether they went to the CT scan before or if that code was put in after they went to the operating room. But thank you for that question.
Luke Neff from Wake Forest University. Great presentation, interesting data. One of the things that has struck me is just the fact that there is a lot of heterogeneity in terms of who's taking care of those children. And you know, you define it at I believe it's less than 18. And so a lot of centers that are even, you know, pediatric trauma centers are being directed and cared for by adult trauma surgeons, you know, who will admit these patients or do the initial stabilization care and then admit them to the ped surgery service, or they just, anything over 16 is going to the adult surgeon. So were you able to tease out, or did you see any differences when you looked specifically at just 16 plus, or, and it probably was hard to do with TQIP data, account for whether or not some of these centers were having, you know, receiving children and being cared for initially by adult trauma surgeons with maybe a different perspective on that? Thank you.
Thank you for that question. That is a great insight. You know, we didn't look at specifically the children that were over 16 years of age, but we did define the standalone pediatric trauma centers, and we did make comparisons between those and adult trauma centers with a pediatric wing. And we found really no difference between the entire cohort of patients and whether they received blood prior to going to the OR. So it seems to be a problem among all centers.
My apologies. In the interest of time, we're going to need to move on. Thank you.
Thank you.
Our next presentation is a comparative analysis of surgery first versus endoscopy first for pediatric choledocholithiasis, presenting at the end of the week. A multi-center study presented by Dr. Jessica Rao out of Wake Forest on behalf of their multi-center group. Dr. Rao, welcome.
Thank you. Thank you for the privilege of the podium. We have no relevant disclosures. We did this research because the incidence of choledocholithiasis is increasing in step with childhood obesity and better detection on ultrasound. Generally, in children and adolescents, the management favors an endoscopic first approach, which is a two-step process involving upfront ERCP with lap chole under a separate anesthetic. Why should you care? Well, we're calling for a change in the default management of this disease and encouraging you to bring patients to the operating room first, regardless of laparoscopic common bile duct exploration abilities. A surgery-first approach allows for the opportunity for a definitive intervention under a single anesthetic. It begins with an intraoperative cholangiogram that serves as a gateway for therapeutic interventions ranging from simple maneuvers such as power flushing and glucagon, and ranges to advanced techniques but very accessible techniques that fall under the category of transcystic laparoscopic common bile duct exploration. Briefly, our preferred technique involves a ureteral stent, a floppy-tipped guide wire, and allows for balloon angioplasty, dilation of the sphincter prior to additional flushing. To see and learn more about what we're doing here, scan the QR code found here and we'll be again at the end of the talk. We have previously demonstrated that a surgery-first approach decreases length of stay and is safe in children. Additionally, we've shown that LCBDE performed outside of traditional working hours is both safe and effective in adult patients. And our goal was to see if these benefits persisted in children and adolescents that present in these lower resource periods of the week. The CARES working group conducted a retrospect cohort study of pediatric patients with suspected choledocholithiasis. These were all academic centers, but had both geographic as well as practice diversity, including variable usage of LCBDE. The primary outcome that we looked at was length of stay. The secondary outcomes are listed, and the time to intervention was defined as time from admission to lap chole or postoperative ERCP. Those who received their lap chole outside of their index admission were excluded. The work week was defined as those that presented from Monday through Thursday, and the end of the week was outside of that period. The surgery-first approach involved upfront lap chole with IOC, and LCBDE was performed at the attending surgeon's discretion and defined as wire access into the duodenum. Various methods were used to clear these obstructions, including nitinol baskets, balloon sphincteroplasty, and choledocoscopy. Those who were unsuccessfully treated with LCBDE underwent postoperative ERCP. The endoscopy first group was typically admitted to the PEDS GI service with an adult consult for upfront ductal clearance and underwent their lap chole during the same admission. Out of the 7 centers, 354 patients were identified meeting criteria, and the only difference in baseline demographics was the BMI was higher in the surgery first group, and roughly equivalent number of patients presented during the work week as the end of the week. There are many important outcomes listed on the left. We'll take them one at a time. When looking at the total operative time for laparoscopic cholecystectomy, it was higher in the surgery first group, likely owing to the additional time for IOC and LCBDE maneuvers. However, when you looked at the total procedure time, which included both the lap chole and ERCP, there was no significant difference between those treated with surgery first or endoscopy first. And importantly for this analysis, there was no difference in operative time or total procedure time when comparing those that presented during the work week to the end of the week. This extra time in the operating room appeared to be time well spent. You'll note that the surgery first group had over a day and a half shorter hospital length of stay when looking at patients that presented at the end of the week. When looking at time to definitive intervention, unsurprisingly, the surgery first group received more prompt definitive intervention 44 hours earlier than those that received their ERCP first. When considering anesthetic exposures, the surgery first group was able to be managed definitively with one anesthetic close to 80% of the time. Also important to note, in the endoscopy first group, some of these patients, almost a quarter, required 3 different anesthetics. When considering complications, importantly, surgery first was not associated with an increased rate of complications, nor were there an increased complication rate at the end of the week versus the work week. So to conclude, children with choledocholithiasis that presented at the end of the week had a decreased length of stay and time to definitive intervention when treated with surgery first. A surgery first approach was associated with a reduced number of procedures and complications, regardless of the time of presentation. Adoption of laparoscopic common bile duct exploration techniques can both improve patient outcomes and improve hospital resource utilization. To learn more about what we're doing, we have a hands-on break shop today at 4 o'clock in Pinnacle Peak 1, as a shameless plug. We're going to go over various LCBDE techniques as well as a surgery-first pathway for approaching choledochlothiasis in children. Thank you for all of the centers that have contributed to this hard work.
Thank you, Dr. Rao. The presentation is open for discussion from the audience.
I had one question. Were at any of those centers, was there a combo surgery ERCP cohort? Obviously, that wasn't what you were looking at, but were there a percentage of patients that had that performed?
None of our centers employed same anesthetic ERCP with flat chole.
Please.
Can you hear me? So Casper Wong from Toronto. So 2 questions. One pertains to the surgery first cohort. Did those patients get surgery first sort of by default because ERCP requires a transfer, which sometimes is necessary to go to an adult facility or just to get somebody to come? And then the second one is related to clearance of the stone laparoscopically. I have found it actually very, very easy and have never been able to not get the stone out. So I'm curious, in the particular cases that required an ERCP afterwards, why that might be, if there was a technical aspect, if there was a particular type of equipment that was available, or was there a technique that was utilized that is not as readily clearing as others might be. So thank you for your presentation.
Sure. The first question, just addressing the surgery first cohort, it did vary amongst the 7 centers about how who went to surgery first versus endoscopy first, as well as changing over time and as practice patterns changed amongst those 7 centers. Addressing the second question, the LCBDE techniques are only used in 5 of the 7 of these centers. Actually, in this cohort, only 40% underwent LCBDE. Many of these patients were able to be cleared successfully with just power flushing and glucagon alone, over 80%. So I think that's why we wanted to highlight that a surgery first approach, even without LCBDE always used, is a successful technique.
Very good. Thank you for your presentation and discussion.
Our final presentation will be a novel high-fidelity in vitro model of esophageal button battery ingestion, demonstrates benefits of honey and acetic acid, presented by Dr. Danielle Windling-Kem.
Thank you for the opportunity to present our data. We have nothing to disclose. So button battery ingestion is a significant healthcare issue, and as Dr. Powell pointed out yesterday, this should be prevented. However, almost 3,500 ingestions occur per year in the US. So the guidelines recommend oral administration of honey before endoscopic removal and endoscopic irrigation with acetic acid. However, there's only a small number of studies available to date, and the in vitro models have some limitations. For example, they did not include saliva flow or peristalsis yet. So we thought that by including these factors in a new model, we may further support the use of honey and acetic acid. So this is a picture of our model. We obtained porcine esophagi from the local butcher and suspended them on a grid in an upright position. We placed a suture at the lower end to mimic the anatomic constriction, and we placed an infusion line at the top for continuous saline infusion to mimic saliva flow. Also, we manually performed peristalsis movements once per minute. And we had a sham group, a button battery group, and a treatment group. And here we started irrigating with honey 5 minutes after the insertion of the button battery, and we used 10 milliliters of honey every 10 minutes according to the guidelines. We kept the body temperature and humidified the specimens. After 1, 3, or 6 hours, we removed the button battery, cut the lumen open and in half, and we irrigated 1/2 with acetic acid and the other half with saline. And for comparison, we performed all the experiments also with a previously described model by Anfang et al. As our reference model. As we measured the voltage of the button battery, we found a reduced discharge of voltage with honey in both models. Next, we measured the pH of the mucosa at the end of the experiment, which is increased by the button battery's current. And here we found a reduced or a reduction of the alkaline pH in both models. However, this reduction was significantly greater in the new model. And this may become relevant when we test other food that may be potentially mitigating also in the future. Then we inspected the tissue after different exposure times. And here is the sham group. In the button battery group, we see an increasing ulceration and necrotic areas with increasing exposure times. And in the treatment group, we see the mitigating effects of honey for all exposure times. However, when we compared this to the reference model, we did see mitigating effects of honey only after short exposure times, and after 6 hours of exposure, we did not see any mitigating effects anymore, and this is important for the clinical setting. Then we assessed our histological sections, and here in the sham group, we did not see any difference between irrigating with acetic acid or with saline. In the button battery group, we saw an increasing depth of ulceration with increasing exposure time, but also no effect of acetic acid. And in the treatment group, we also didn't see any effect of acetic acid, but we could confirm the macroscopic findings with the honey mitigating the ulceration. In comparison, in the reference model, we also did not see any effects of acetic acid, and we could confirm here the macroscopic findings as well, that after 6 hours there was no mitigating effect of honey in the reference model. So in conclusion, in the new model, we added continuous saliva flow, peristalsis, and body temperature, and compared to the reference model, we saw a greater reduction of the alkaline pH and a stronger protection against ulceration, so that we can confirm the mitigating effects of honey in the new model. However, we did not see any effects of irrigation with acetic acid. I would like to thank everyone who worked on this project, especially Charlotte Reich, who's also here, and thank you for your attention.
Thank you very much for that presentation. We'll open up to questions now. Please.
This is not Sean Kanisaki, Johns Hopkins. A really phenomenal talk. I really commend your group for trying to recapitulate a lot of the early studies, which I think are the basis for the 2022 AP Button Battery Task Force recommendations. But based on your data, are you suggesting that acetic acid probably is not very effective?
From what we found, yes, but certainly there are more studies needed, especially clinical trials. We did not find any harmful effects, but we did not find any benefiting effects either.
Got it. And did you also look at Carafate? Because that's also an alternative agent based on the Button Battery Task Force guidelines, or have you just focused on honey at this point?
We just focus on honey, but certainly for children under the age of 1, we cannot give honey, so we'll also have to look at that.
And my final question is, these are, you said, esophagi that you got from butchers, so these are presumably adult pig esophagi. I would presume that this study would be more sensitive, or you'd get a lot more interesting information if you looked actually at anatomic appropriate sized esophagi because of the thickness of the esophagus, et cetera.
Yeah, certainly there's a difference because it's also the uppermost layer is thicker in the porcine esophagus, so we cannot really, there is a difference, so it's only an in vitro model. And it's probably a good idea to maybe use younger pigs.
Great, thank you.
All right, please.
Hey, Ben Sandejas, Boston. Great study, thanks. A couple thoughts and questions would be, some of the thoughts is that the irrigation helps to sort of clean things up, and after you remove the battery, get rid of that ongoing damage that happens after the battery's removal. Now, the mechanism, or at least the practical thing for honey, is it's given before the battery is removed. Now, so how do you put that with your study results in terms of like, should we be applying honey at the time of removal in the OR, or I think just the practical applications of how do you envision this going forward?
I think the idea is to give honey as soon as possible, so even at home, so that it can work as soon as possible. And in the OR, you just remove the battery and then irrigate with saline or acetic acid, whatever the future studies will bring. But the honey should be administered as soon as the parent notices that the child may have swallowed a button battery.
Yeah, no, but with your data, it almost begs the question as to if they didn't get the honey and you're in the OR and you just removed it, should you, put some honey on it? That's the question.
Oh, I'm sorry, I didn't get the question. Well, I think the mechanism of the honey, due to the viscosity, is also to insulate the battery. So once the battery is out, probably just irrigating will be enough, maybe enough.
All right, thank you very much.
Thank you.
Appreciate it.